Welcome to our National Research Testbed TMIT High Performer webinar series, and today we've got some wonderful speakers and reactors for you. The title is Engaging Patients and Families as Partners in Patient Safety. I'm Charles Denham, Chairman of TMIT, and I'm just going to make introductions and moderate the Q&A session with just a little bit of an introduction on some important papers that are coming through. Want to make sure I'm on slide 3 that everyone has turned their volume all the way up on their computers so that they can hear the webinar. And if for any reason after you do that you don't have good audio, you can click on the telephone icon in the lower left-hand corner of your screen down at the bottom and request a separate line, and we can give you a separate line. Slide 4 is where you go if you don't already have the slides in a PDF format, and if you want in future to be able to listen to the webinar again, we will archive it for you. And you go to www.safetyleaders.org, and there you will be able to access it. And you'll see, if those of you that are looking at the slides right now, you'll see speaker link. I just want to remind you that we have wonderful speakers. The majority are patient advocates that can come in and tell great stories and help you with your healthcare quality improvement initiatives, and remind you about SpeakerLink, which is a free service that we provide to everyone. And when you click on safetyleaders.org, in the upper right-hand corner, you'll see in the menu section what's new, and you'll be able to click on the link that will lead you to where this webinar will reside. You see the wonderful pictures of Mary Foley and Karen Curtis on the slide that I have, slide 5. I just want to remind everybody we're on Twitter and Facebook, and you may click on those and go to related sites and actually watch our documentaries, which are also provided free. Slide 7 is our calling to save lives, save money, and create value in the communities we serve. We're often asked, how come you don't charge for anything at TMIT, and how come you don't ask for donations? And it's because this is really a gift back to the community focused on this calling. Our disclosure statement and those of the speakers are on slide 8. I won't read them in detail, but they're up, along with our slide 9 of certification of our disclosure. And now our speakers and panelists today: Karen Curtis, Mary Foley, Hillary Schmidt. We have of our team Matt Listiak and Colin Gabriel as well, and Arlene Salamandra, who will really open us and kind of help us set our sights on what's most important here. We always start with the words of the patient and family, so we make sure to get grounded in where we're centered. And so we'll ask Arlene to open us with a 30-second statement to get us focused, and she'll also close us at the end of the webinar. Arlene is a wonderful contributor. She has been a tireless champion of patient safety and quality. She, from her own tragedy in her own life of patient safety, led her to give back to others. And most recently, she's one of the most courageous champions for reduction of bullying and misuse of power in the healthcare workplace. And so she's also been a co-author of papers with us in the Journal of Patient Safety, and a national speaker and contributor, and has a great experience in nursing homes and care of the elderly. Arlene, would you really get us started?
Oh, thank you, Chuck, and thank you for all those kind words. I guess it's in all our hearts to make things better. And I just want to thank everybody for being here for the webinar. I'm really looking forward to the presentation and what I'll be learning today. I think we never stop learning, and that learning comes from a lot of different views. And we come from a lot of different roads, and together we can find that common path to make healthcare the safest and the most rewarding, too. I know the delivery of medicine is very complex. As caregivers, and I was one too for a very long time, we're in medicine because we care about our patients and how we can make a difference in their lives. So I just want to let everybody out there know that I appreciate that you're on this call, on the webinar today, and thank you for helping. So thank you, Chuck, again for having me here, and back to you.
Dr. Denham, you there? Arlene, I'm sorry, I have my phone on mute, trying to be respectful. Arlene is one of our greatest contributors to a every other week group of leading patient advocates who work with us on really the direction that we're taking. I just wanted to set the stage with only a couple of minutes because I think we've got two tremendous speakers and some great reactors on some recent highlights in the literature that I think are really important to us. One is an article that you may or may not have seen, but it is very, very valuable to you as a safety, quality leader as well as a patient advocate. And for those of you that are champions, non-clinical, professional healthcare advocates, as well as those that are in the clinical professions and the administrative professions. It's a great article in the Proceedings of the Mayo Clinic entitled Patient-Initiated Second Opinions, a Systematic Review of Characteristics and Impact on Diagnosis, Treatment, and Satisfaction. Those of you that have been with us along the way with our webinar and our national test bed, we have really focused on misdiagnosis and incomplete diagnosis and also in the NQSA practices. This article really provides the evidence with a very thorough review of why we need to get second opinions, not only for procedures that are very expensive and could be potentially life-threatening and significant to your life, but also with the more expensive and more comprehensive diagnostic studies. And as you all know, we've focused on the 5 rights of imaging, which helps us really understand overuse, underuse, and misuse of both tests and procedures. Highly recommend this article. A second article that came out in the last 2 to 3 weeks was in Modern Healthcare, and the cover of the Modern Healthcare issue was the ratings maze. And this article addresses all of these different scorecards that you see with the logos on the right-hand side. And we have a number of polling questions that we will ask you to answer regarding you as a healthcare leader or patient advocate regarding the value you believe each of these scorecards have for guiding the care of patients and families and family engagement. In this article, they question the hospital raters' methods. We know that this is in the beginning of the beginning. Scorecards are critical. They're very valuable. But we're really at the beginning of this innovation, and the big gaps between them where you'd have a top 5 hospital in the U.S. News and World Report that gets a C or a D with Leapfrog, or certain numbers by Hospital Compare that don't sync with the other ratings really cause confusion to consumers. And we believe, having been one of the most steadfast supporters of Leapfrog and having written the original survey for the safe practices outside of the original 3 leaps, and because we provide the software system to Leapfrog, you can tell that we really believe in these scorecards. But they're the beginning of the beginning, and they're very, very incomplete, and they're very confusing. So this article, I think, is a good review of that issue. The next article I want to remind you, and I get the daily brief from the Cleveland Clinic, the Internal Medicine Daily Brief, and it addressed the Commonwealth Fund new report that shows that the United States is ranked 11 out of 11 of the industrial nations for access and efficiency and quality. We didn't do a whole lot better, and I highly recommend this excellent report by the Commonwealth Fund. So for those of you that are educators, this provides you, I think, with some very good rock-solid statistics that can help you. And I'm on slide 19, just giving you an example of the overall rating and how the countries did. I'm not going to go through this because Mary and Karen have a wonderful presentation, but I didn't want a day to pass without you knowing about this. And then the final article, because we're very actively involved in health, wellness, fitness, as well as patient quality and care, and especially obesity and prevention in children and adults. I was recently at a global meeting in Stockholm where the editor-in-chief of The Lancet was, and they released this article so that if any of you want to look at prevention of childhood obesity and diabetes, and you want the latest reference that has really rock-solid numbers, this was funded by the Gates Foundation with numerous authors. So that's my quick review of some, I think, really terrific areas that we want to address. And we are now going to move to Karen Curtis and Mary Foley, and I'm going to introduce both of them and then allow them to then sequence themselves, accordingly in their presentation to you. And they are both wonderful individuals, great patient safety champions. I'm going to allow them to share their passion and why they have their passion. But Karen is the author of a hospital handbook for patients and families, safe and sound in the hospital, must-have checklists and tools for your loved one. And we have no financial relationship with her, so that we can tell you with 100% clear, fully disclosed, no relationship financially, that this is excellent work. I recommend it to everyone, caregivers, patients, and families alike. She's also the founder of Campaign Zero and at www.campaignzero.org. She developed the resources after her family suffered multiple tragic losses from never events in hospital care. She draws on a 25-year career in market research consulting to Fortune 500 companies. So she really brings some great tools to those of us that are in the safety and quality movement. She's applied her professional skills to study how hospital care is managed, where gaps in care are most common, and where the best nursing practices to prevent them exist. She's distilled that information into simple checklists that anyone can follow. They're evidence-based and written at a sixth grade level, which we know is absolutely critical for health literacy. And Mary Foley is just another national treasure. And Mary is a wonderful healthcare educator. She was the former president of the American Nursing Association, a longtime collaborator with us, co-author of a number of papers. She also was a co-author of the section in the National Quality Forum Safe Practices for Patients, as was Arlene and Dennis Quaid and others who we recruited to help build that piece into the safe practices. She is the director of the Center for Nursing Research and Innovation at the University of California, San Francisco. She's worked with the center as an associate director since 2004. She's worked with the Collaborative Alliance for Nursing Outcomes since 2004, and in 2009 was appointed Director of Education Services. And in that role, she developed an area of expertise in nursing sensitive care measures with an emphasis on medication safety. As I mentioned, she was the former president of the ANA, and I think more importantly, Mary brings such a sense of authentic wisdom to the academic side of medicine and helps us really bridge practical care of great caregivers. And she's one of our really wonderful leaders in patient safety and quality who has a real positive vision for the future. However, she's grounded in the reality of the care we deliver today, as is Karen. So these two have worked together, and we really are very pleased to have them working together with us on this presentation. So with that introduction, I'm going to mute my phone and look forward to their presentations. Ladies, please take it away.
Thank you, Chuck.
Thank you. That was a wonderful introduction, Chuck. And we've organized this presentation so that I will speak first, and this is Karen Curtis, and give a little background about how I came into this work from, of all places, a corporate career in marketing, and how I've applied a lot of what I've learned during those first 25 years to fundamentally communication problems and solutions in healthcare. Then Mary will take over to talk about some tangible tools that we've developed together. Mary and I have a lot in common, and we're great collaborators, but I think the thing that drives both of us most is that we are both so committed to developing and providing real-world, actionable, adoptable tools that patients, families, and care providers can actually use to advance safe and sound care in hospitals. The word patient-centered care and patient and family engagement are really kind of broad umbrellas, and it's kind of hard to know how to wrap your arms around them and actually move them forward. So by the end of our little presentation today, we hope to leave you with some tools that you will be able to go forward with improve on, adopt in your own organizations, in your own hospitals. And we welcome your questions. We welcome your feedback at the end. Mary, would you say that that's accurate with what our goals are today?
It certainly is, Karen.
Okay, so as Chuck mentioned, my family was irreparably harmed from a couple of different interactions, I guess you would call them, in healthcare. The first was with my father. His name is Bill Ite. I'm married to my mother for over 50 years, and he was diagnosed with idiopathic pulmonary fibrosis, which you may know is a devastating disease with no cure except for a lung transplant and really no treatment options that could even alleviate the symptoms very well. We felt very optimistic, however, that of the 1% who have this horrible diagnosis and are able to get a lung transplant, that my dad would be one of them. We're kind of a cup half full family, and we petitioned as Dad neared what they called end stage. We petitioned 16 different transplant centers all over the country, asking them to take a look at his records and to review him as a possible candidate. We were absolutely delighted and felt like we had really won the lottery when Dad was granted a lung transplant at a medical center known as the very best transplant facility in the world for both lungs and heart. They do the greatest volume, and of course, isn't that what you look for? And the surgeon who actually did the transplant pioneered the procedure. So we were blessed beyond measure when Dad received that transplant because his IPF was cured, and he was looking forward to, as his pulmonologist said, a few more rounds on the golf course within months of the transplant. He received it in February, and his pulmonologist even went so far as to say that he would be back on the golf course by the 4th of July. So that was the vision. Unfortunately, about 6 weeks post-transplant, when he had been, shortly after he had been out walking, a nurse took him to the bathroom, and he was cautioned to wait for her until she returned, but I don't know how long he was there, but he decided he was just going to go back on his own. And he took a fall just short of the bed, hit his head, and a goosebump raised on his head, which was a very long story, but they put him in horizontal traction, and he was told to just sort of sit tight until a neurologist could evaluate him, which was promised to be within just a matter of hours. This happened on a Friday afternoon, and a neurologist did not come in to evaluate him until Sunday night, and he had been horizontal for nearly 57 hours. He was cleared for takeoff with a 5-minute, really just quick questions, you know, who's the president, what's your wife's name, what's the date, follow this pencil, and he was deemed to be perfectly fine. Unfortunately, the next morning, Monday morning, he was admitted to the ICU with pneumonia. And he had become actually more ventilator dependent over the weekend. He was just supposed to be on the ventilator in the evenings, but over the weekend he couldn't walk around and his lungs were filling up, and they put him on the ventilator for longer and longer periods of time. So he did end up with ventilator-associated pneumonia in the ICU. He recovered from that, and he was back on the floor again, but then he was diagnosed with MRSA. So back to the ICU. And after recovering from the MRSA in the ICU, and he was again back on in his normal room on the post-transplant floor, he was diagnosed with C. diff. Back to the ICU. While he was in the ICU, of course, at that time, ICU patients were not allowed to walk, and deep vein thrombosis was diagnosed, which quickly resulted in a pulmonary embolism, and that embolism lodged in his new lung, which did curtail some of his breathing ability. He was recovering from that when MRSA struck again, and then C. diff. So by the 4th of July, actually, Dad was just in horrible shape and had no strength left. He was in the midst of a really terrible bout with C. diff. So 9 months after Dad, or 7 months after Dad's transplant, he passed away. Shortly after that, about 3 months later, my husband was admitted to the hospital for a routine bowel resection, and he ended up with sepsis and a VRE infection that he picked up after emergency surgery to remove the dead tissue from sepsis infection. Then finally, a few months after that, our son was misdiagnosed with appendicitis. So as you can tell, we spent about 15 months total, mostly in hospitals. I think looking back on it, we assumed that the mistakes that we made centered around our assumptions about patient-centered care. Though we did not know the term at the time, and I only learned that term actually later after digging into just everything that I read afterwards, we had assumed that all of the systems and the procedures for taking care of patients would really center on what's best for patients. And we don't have a lot of time here today for me to point out specific examples of where that assumption did not hold up. But in the end, I think that's really what it was the disconnect between what we always assumed that would be sort of an all-for-one and one-for-all kind of collaboration that we expected among all the doctors and nurses, the family, and of course with my loved ones at the center of it, and then what actually happened. What we actually experienced was highly fragmented care. And I can't even tell you how many times I heard the phrase, well, oh, you know what, that just seemed to fall through the cracks. That test fell through the cracks. Your dad's chart fell through the cracks. Oh, the medication list. Well, I guess it just fell through the cracks. We didn't realize he was already on heparin. So things like that happened. And we were, and my loved ones actually paid the steep price. At the end of this, when everyone was sort of whole again, and it had been about a year since my dad had passed, life was getting back to normal, but I found myself, as my husband said, crying at stoplights. I just couldn't stop crying. It was, I had a happy life, definitely blessed in so many ways. Wonderful, wonderful life, but yet I couldn't stop crying. In fact, my kids, I didn't want them to know that Mommy was crying all the time, so I kept a basket of onions on the kitchen counter, and if I would feel my eyes start to leak a little bit, I would simply say to the kids, oh, look, Mommy's just been peeling onions. We're having onions for dinner. But it actually began to stand in for something else for me, and that is I felt that I needed to peel the onions for answers, and that's what I did. I drew on my long career in market research, and I decided that, work had always been great therapy for me, so I was just going to dive right in and figure out what the heck happened. I had been diagnosed with post-traumatic stress disorder And that diagnosis was great. It sort of gave me a sense that what I was going through was probably pretty normal. But really what helped to normalize my sense of the just the loss, I guess, was that I learned that our family and what we experienced was not, we were not outliers, that we were part of a trend, and that I learned 1 in 3 patients are needlessly harmed or die from preventable adverse events, or something that we would call never events. That term, oddly enough, was actually comforting to me, because all along I had been thinking that we were sort of crazy, or that we had just enormously bad luck, or that, I don't know, it just all seemed so so scary and foreign and just unimaginably odd that our family would be so marked. However, when we learned that, I learned anyway, that unexpected or unintended consequences to care are that 400 lives are lost every single year, and that it's the 3rd leading cause of death in hospitals at a great expense. I thought, too, that when Mark Chasson came up in, I think it was, he spoke at IHI conference in December of 2013 at the Joint Commission. They had taken the time to sort of crunch the data into even finer points, and his keynote at the IHI conference a year ago presented the fact that air travel is 3,000 times safer than hospital care. When you think about it, it's kind of ironic, isn't it, that there are so many of us, including myself, who are white-knuckle flyers. But yet, when I think back to all the times I went through the doors of the hospital, I actually felt like I was entering a place that would offer comfort and care. And I didn't at first have any sense of worry or concern. I felt relief that the hospitals were there to take care of my family. I often don't take that kind of relief in taking off on a jet, but it's actually the opposite, where we have to go into hospitals, I learned, with a certain amount of preparation, obviously, and a lot of trust, but also, as I tell everyone, we have to be knowledgeable enough to know how to verify and support good care. Something that Chuck mentioned earlier is, and this is just restating the newest data, is that of the top 10 industrialized countries, the United States ranks last in quality and first in cost. And this was just published by the Commonwealth Fund on the 16th of this month, and it's for the 10th year in a row. The United States sits at the bottom and has the highest in cost. So I think all of you, in fact, do smell the smoke. That's why you're on this call today, and why I so appreciate the fact that you are obviously aware of these never events, the common and preventable kinds of unintended harm that occurs in hospitals so frequently. And my guess is that you all want to do something about it, which involves learning a new way to think. For my part, as someone who took all the data that I gathered, and I mustered all of the marketing skills that I have to create a guide for patients and families, it does require for all of us who are healthcare consumers to think a new way. And that is why I wrote this guide for my family and your patients. In simple checklists, I believe we can figure out what we need to know to prepare for a hospital stay and then support good care while we're there. So I did pull together by actually studying nursing textbooks. Believe it or not, I found them to be absolutely fascinating. And everything that I could read, I was able to pull together information about, how and when falls occur, who's most at risk, and then simple checklists for how patients and families can work together with the nursing team to prevent falls. And then the same goes for all of the hospital infections, blood clots, pneumonia, bed sores, medication mix-ups, readmissions, and more. In all of those checklists, I try to teach people what to look for, what to say, what to do, and when to get a nurse. All of those symptoms that may seem subtle, patients and families are more apt to see them before a nurse does, and we let them know in this handy little guide that it's okay to speak up. So one of the reasons why they're in checklists is because we know from work from the University of Michigan and Keystone studies that checklists actually work, especially at the 6th grade literacy level. And throughout the book, I tried to illustrate as much as possible with icons and pictures. We also, in the book, encourage people to take notes and then give them prompts of the kinds of questions to ask. Throughout, I really remember so vividly how emotionally draining every single day felt for me and my mother and my brothers and sisters in hospitals. So I tried to illustrate with some beautiful imagery and inspiring quotes just to address that emotional component that's so necessary to healing. Throughout the book, I tell people that it's okay to speak up and also to wash their hands, and of course why. My book has been out for a couple of years, and I've been really, really gratified to see the comments, especially those that pop up on Amazon, and then others that I get from people along the way who leave notes on the website and so forth. And I'd have to say that the reactions have been universally ones that indicate peace of mind. And I have to admit that I was a little bit worried in putting all of this information out there that it would make people feel uneasy or worried or concerned. And just the opposite has happened. People feel, I think, that the more knowledge we have, the better off we are. And so the peace of mind that comes from knowing how to prepare for a hospital stay has really been a wonderful byproduct of all of this good information. We know, too, the data, too, has shown us that activated patients, those that do have information about their own health care, have better outcomes, lower costs, and greater satisfaction. I don't know if you're aware of it, but this is a great study that was done by Judith Hibbard at the University of Oregon, and the citation is below if you would like to read it. We also know that activated families, and that word activated is a stand-in for engaged and informed, is that families need to know just as much as patients do, because we do know that patients forget about up to 80% of what their caregivers tell them. So the family members really need to be there and present to hear the same kinds of things and to help fill in the blanks for their loved ones. In turn, no one is more patient-centered than families. They want to collaborate with you, and no one knows your patient better. So there might be some information that you can pick up from patients' families that the patients themselves might have forgotten or have not been able to remember to share with you. My concern along this, I have to say, and have to be very, very candid about this, is that I have been worried since the very beginning about patients and families coming into hospitals with their checklists and having all kinds of permission in my book to speak up, ask people to wash their hands, and to be very forthcoming with their questions and ideas, and to share them. In my book, I always talk about, well, share these checklists with your caregivers. That way you're all going to be operating on the same page. But I was very, very worried that caregivers would just throw us, patients and families, under the bus, that it would be very uncomfortable for some doctors and nurses to hear patients, for example, insist on hand washing. And one cross look from a doctor or nurse would make a patient or family member run for cover. So with that, I was incredibly blessed to meet Mary Foley, because she, of course, is not only a wonderful educator and with a long career in healthcare systems, but she completely understood my concerns, and together we wrote a book that complements Safe and Sound for Patients and Families with Safe and Sound Nursing Tools for Patient and Family Engagement for Caregivers. So I would like to hand over at this point to Mary to take up and share these tools. Mary?
Yes, hi. Thank you very much for that excellent introduction, and it really helps frame how you got into the work, and as a family member, why you've really dedicated yourself to this work. When I met Karen at a meeting and invited her to share her story with me, I was presenting at the Nurse Leaders Conference in California, and this is now 3 years ago. We've actually been working together that long. It was really unscripted, and we had never presented together, and the impact that Karen had in the room with the California nurse leaders who heard her story. There were tears, there were apologies, but more importantly, people were struck by the fact that they had never heard a family member share their experience and really did not know some of the pain that is experienced or what to do about it. So it's time for us to, partner. When I heard Karen's story, I said, that's great, but the nurses, I'm not sure and I love nursing. I've been a nurse for 41 years this month. But I was a staff nurse for many years and a chief nurse, and I thought, what if somebody just walks in with this handbook and tells me they're now my care partner? How will I respond as a nurse? So we're actually ready for the next slide to get us moving into this presentation. Okay, so it was important from my perspective to find a way to communicate to the nurses what it is that the patients and families will now be equipped with, where that evidence came from, so that we're working from the same evidence-based model, so that there's nothing in Karen's content or in the nursing tools content that isn't quality forums, CDC, Joint Commission. We really have done our homework on making sure that all of the recommendations are appropriately vetted and are the standard of practice in U.S. hospitals. And this really is, at this moment in time, a hospital-based activity. It has unbelievably positive opportunity and implications for non-hospital settings, but in all honesty, this is where we needed to start. I want you to know just real briefly, QSIN, which we reference on this slide, is a relatively new program, Quality and Safety Education for Nurses. It's primarily in schools of nursing where students are learning new competencies that embody the knowledge, skills, and attitudes necessary for them to practice safely and to be mindful of safety initiatives. Karen and I presented last year, and after a year of really evaluating our work and how it aligns so nicely with CUSIN, they invited us to be at their conference this year and then did an endorsement. We're seeing CUSIN competencies slowly be introduced into the actual practice setting, but our new grads right now may be holding the tools in how to practice more fully and consciously from a safety and climate. So clearly, we wanted to make sure that we were on course if we were going to present anything to nursing leaders and to nursing staff, and to be honest, to medical staff and to medical students, because we think this is a great translation of research into practice, not just for nurses, but for physicians to be accepting of a fully engaged and activated family who we've told them, please ask questions, be involved, and assert yourself so that you can then give the best care possible, particularly when this person is in your care. So I'm ready to keep moving here. And
okay.
Yeah.
I'm advancing the slides, Mary.
Okay, if somebody could, that would be great.
Yeah, okay, I can do that.
Okay, so the Safe and Sound collaboration really is built around the concept that we want to connect in the three ways, and Karen has done a number of slides that will reinforce the three ways in which to connect with people, but it's the head, the heart, and the hands. In other words, we have facts using the head, and we have heart, where we're really working with empathy. Today is not a good day to spend a lot of time on the empathy because it really conveys best when you're working in person. But we do give these classes to healthcare facilities across the country that are trying to introduce this work into their environment. It's very gratifying. But certainly the tools are critically important because we want to be very practical and tangible. I have said for years, and I say this when I work with Karen, I work with nurses to give medications more safely. And if I just say to them, give your meds more safely, I've given them the goal, but I've given them no tools to do that. Telling our staff and our healthcare community to be more patient-centered is really only stating the goal. And what we're trying to do is give one set of examples and tools and messaging that can help us become more patient-centered in our actual practice. So rather than it just being theory, which has been supported by research, we wanted to certainly be more effective and tangible. Okay, so we need to keep moving the slides. I don't know who's doing that. Okay, so in Karen's work in the Safe and Sound for the family member, we've matched the work in the nursing toolbook so that the nurses are familiar with what family members are coming in with. But Karen has designed very basic toolkits, again, relying on the checklist methodology, which really helps people organize. So, for example, the slides that you're looking at right now with the green hard hat, and we use the hard hat, we actually take them to the classes to say, this is hard work. This is different work than we're used to doing it because it is, A, in team and in partnership, and it's also very conscious communication and tangible tips. So here's fall risk prevention, including the, how to communicate about the falls, how to be empathetic. I know you don't want to call us for help, but you have to. And because you had a fall in the past, we are going to give you these special slippers. We're going to do all these extra steps. We're going to put some signage up to let people know that you've had an injury. So we really match the head, heart, and hands. So the rubric again and again and again is how to use the written or spoken word, and it's been well documented, and particularly coming from the marketing field, that facts really need to be shared at the 6th grade literacy level. And that's hard for folks that have studied medicine and nursing and pharmacology and social work and infection control. It's very hard, and it's not the dumbing down. It's a clean and simple communication. We tend to speak fast. We use a lot of abbreviations, and we use a lot of inside the beltway or ballpark terminology which, as healthcare providers, we can understand among ourselves, but not well understood by the community or family members. So terms that seem simple to us, like decubitus ulcers. A bed sore is what most lay folks, or a pressure ulcer, and maybe even the pressure ulcer being a little too obtuse, is very important. Bacteria, organisms, all of those terms that we use around the infections. What we've learned as kids is there are germs out there, and those are actually terms that work quite nicely. So how to share the facts, and I can tell you that this takes practice. This takes, it really is hard work to speak plainly. Karen and I role modeled this for our first time at a workshop in Ketchikan, Alaska last month. And she sprung it on me, and I was the nurse trying to communicate with her about some situations. And she kept pushing back as the family member, trying to get the room, it wasn't just me, but the room of primarily nurses, to speak plainly. One of the best examples was an infection control nurse who said, your dad has an MDRO, and we have to put him in into isolation, and he's now on contact precautions. And what we realized was that would be completely lost on a family member. And what it's communicating, or in the severity of it and what the implications are, really needed to be worked through. And it took quite a while for the whole group to find the set of words that worked. So Karen, keep hitting that slide because it advances through the examples of how to speak plainly.
Okay.
Maybe it's not going to come. Yeah, it is. Okay. So let's keep going and get this slide fully exposed. There you go. So there is a tool in Word in the Microsoft Word that you can actually check for readability statistics, and that's a recommendation so that you can get to the 6th grade level. Definitely try rehearsing, and rehearsing with your staff, and if you have a family education council, work with them and have them check this work with you. And don't forget the written communications, the admitting package, the discharge instructions, patient care guidelines are all written by professionals and generally for professionals. So it's an opportunity to really not only speak but write plainly. And this is work that I think will be very important for us to proceed with. Next. So in terms of the heart, and we're going to go very quickly through this. It's just a slide showing you that there's a wonderful film by Bren Brown that really illustrates the power of empathy and what we want to be are good listeners and really feel with people their vulnerability while going through a very scary experience in the hospital. So it allows us to be with them. It's not misguided sympathy, but it's an important heartfelt connection, and people know it when you mean it. They can feel it too. Okay. So the tips, here are the tools. So here are the hands, and these are the tangibles that are just a set of recommendations, and each healthcare facility is on its own journey to have a safer environment, to work on the never events, and to engage patients. Some are at the beginning of that journey, and some are quite sophisticated and have done a great deal of work. So again, the checklists work both for patients and families and for staff. But we also think we need to put in front of people the tangible tools where they will then be able to provide a safer and cleaner environment for their loved ones and for the room and for themselves while they're in the hospital. So, generally speaking, a lot of these pieces of equipment and cleaning products, they're kind of stashed away in cabinets and cupboards. Let's get them out. Let's let people help clean those handrails and clean the tray table and get the environment as clean as it possibly can be. There's just too much to be done to assume that one swipe by housekeeping, and they do a wonderful job, is sufficient. I had unexpected became the family member caregiver of my loved one who had a cancer diagnosis last year, and after 6 rounds of inpatient chemo and a stem cell transplant in December, she's back to work this week, and it's pretty exciting to see her in recovery. But I went through, as it turns out, 7 hospital admissions where I went in as the cleaning caregiver. I lived what Karen's recommendations were. I had the book with me at all times, and I took copious notes and had to keep track of a very complex set of care plans. And I had, out of 7 experiences, 6 very good feedback moments where folks said, hey, that's great, you're cleaning. And of course, I'm a nurse. I knew where to go find the cleaning supplies. I knew which were the real Clorox wipes on the bottom of the computer cart. And I would just go get my own supplies. Not everyone has that knowledge, comfort level, or audacity. So we need to make it available for them. I had one staff member, though, look at me while I was doing the cleaning, the gloves on, getting the side rails cleaner and the tray table and under the drawers, places that people touch but are not often cleaned. And she said, what in the world are you doing that for? Are you criticizing that we didn't do an adequate job? So I got thrown under the bus that time. I didn't care. I was still going to do my cleaning. But think of a layperson, think of a family member, and how intimidating that kind of a question or comment could be. So that reinforced why I need this nursing tool book to go hand in hand with Safe and Sound. And we can't underestimate the value of teaching our own staff, nurses, how to think and act differently in true partnership with patients and families. So let's keep going. And these are just a set of tools. Of course, you have the slides, which I think is very exciting. I'm going to focus on the most radical on this list, on the quick tools to provide. And that radical is the idea of making a recording of discharge instructions. And it was actually illustrated at Coleman Regional Medical Center, and I'm not sure where that is, Karen. I think you know. Utah, maybe?
Anyway. It's in Georgia.
Georgia, okay. And
this just came out about a month or so ago,
yeah,
the
this
results,
is relatively new, and the findings on this were hugely high satisfaction scores, and folks said, wow, I could go back and listen, because you think of the fog that people are in and the fog of getting somebody home and the confusion that's created by all of the written word, and here was an audible discharge summary that gave people a chance to go back and hear it again. And for some of us, we learn better listening than we do reading. So this is just, I think, a great example. So just a list of tips and tools that are available to you both in the Safe and Sound book and certainly in this presentation. Okay?
Well, and also, I think it's worthwhile mentioning, too, with this study at Coleman where they sent people home with the discharge instructions recorded, they reduced their readmissions by 15%.
And we know you're all working on that.
Yeah, which they attributed back to this program. And then I don't remember what percentage it went up, but their patient satisfaction scores went way up too.
Yeah.
Their APEP scores.
I'm mindful of the time because I know we really try to keep this in the hour, so let's keep going on
the
slides. And I know our team folks will manage this with us. Can we advance?
Okay.
So again, just reinforcing, we have to be the change that you want to see for your family and your patients and for peace of mind. So, recall the head, the heart, and the hands, and it's the speaking and writing, the feeling, and the tips and the tools. And I think this gives you a framework for tangible change and how we partner with patients and families. And I believe you'll see improvements in patient outcomes, certainly in patient satisfaction. So it aligns very nicely with satisfaction strategies that are underway, and if it could reduce your readmissions, that would be a darn good thing as well. Karen?
I appreciate all the time that you've taken. Mary and I normally don't speak this quickly, but as she said, we wanted to get everything in within an hour. Mindful and respectful of your time, but we do have time for questions.
We will have the Q&A section, Karen, per our outline, our flight plan. After, at the end, we're going to be doing a poll, okay. And we're also going to have some reactors to the presentation. So, Kyle, if you could turn over the control of the slides to me now. Then I can kind of advance and we'll give generous time for potential questions. And we really appreciate this wonderful presentation of some real resources that I think are going to be demanded. As we look at this presentation, and some folks may say, well, I don't know if it's going to be a good fit for us. I can tell you with 100% assurity, working with some of the Fortune 500 companies, that they're going to absolutely start demanding this of their third-party payers. The self-insured companies are going to ask for this because they know that this can dramatically reduce presenteeism, absenteeism, their own healthcare costs, and they're really starting to get a social conscience about their own employees. So in the slide deck, you can get in touch with these great leaders by the slide you see on 71. But what I'd like to do is invite our reactors, our set of reactors, to react to what you're hearing and add some comments. And before I do, I just want to draw your attention to a recent book. So there were the articles that I introduced earlier, and if people have questions or comments regarding those, no problem. Also, this book is coming out. Again, no financial relationship with Carol Sanford, but Mike has gotten to know her very well. She's worked with major countries, major organizations, and her first book is The Responsible Business, and a book coming out is called The Responsible Entrepreneur. And I'm going to ask, after we ask Hillary Schmidt to be our first reactor and have Arlene be our second reactor, I'm going to ask our TMIT team to first comment on their what they heard from the presentation today, but also to just comment on Carol Sanford's work, because I think what we're finding is people are now in top organizations are much more caring of their own employees, and in turn much more caring of those that they serve as customers. And we're getting away from this faceless customer and really starting to talk about real people. I'm going to hand my headset over to Hillary Schmidt and ask Hillary to comment. Hillary is on our core team. She is a world-class leader and one of the world's best leaders in continuing education. She's working with us in our Care University program, both for caregivers and for patients and families. And I'm going to have Hillary, she's been taking notes vigorously here, so I'm going to have her make a couple comments, and then we'll go to Arlene Salamandra, who established us this morning, and then Matt and Colin.
I'm just getting the headset on, sorry. And thanks so much, Chuck, and for that introduction. And also, but really thanks Karen for an incredible presentation and for translating what an absolutely just debilitating and terrible situation into something so positive. Karen, I'm so impressed by how you took tragedy and have made something positive come out of that. And my background is really in the science of human learning, and in continuing medical education. There's so much education around that results in increased knowledge, but it doesn't translate into real actionable practice, new practices. And I want to just thank you for providing these resources, which are exactly what is so few and far between and hard to find in the continuing medical education world, which is really practical tools and resources to help people who are doing their very best in the situations in which they are. No one's trying to hurt anybody. They're doing their best, and they've developed habits. They're under time constraints, and so to be able to have access to the checklist, the tools, the evidence that you've put together in these resources is just so critically important. It's only through having those extremely specific, highly practical guides. It's like having a recipe for how to make change. Do you see the ability of anybody to actually implement new behaviors? And you're working against, it's hard, habits that need to be changed. And you talked about it a lot. I just really want to reinforce it, the critical importance of practice and feedback, more practice, more feedback. And so I just applaud you for having created the how-to manuals to really guide that kind of learning. And I have one question for, I guess, each of you, which is, which I'll save to the end. I'll save to the end. Okay.
So thank you, Hillary. We're going to have a Q&A session right after we do our polling. But what I'd like to do is allow Arlene now to be a reactor to what she heard, and then I'll move to Matt Listiak and Colin Gabriel.
First of all, I want to say thank you, Karen and Mary, for what a great presentation, and for the tools, the safe and sound tools on both sides. You know, the patient does have a different perspective, and nursing and healthcare has another. I think what I would like to see in hospitals, patient engagement is new to everybody, and it's new to the patient too. I remember a time where you just went to the doctor and you did everything he said and was respectful, and those times have changed. Healthcare has become very complex, and there's new treatments and new things to know, and we have the internet, and patients go on the internet now. So the culture of the healthcare system is changing, and I think patients need to change with that too, as well as healthcare providers. And I always thought it would be a good idea if hospitals, as they run these community programs, to have programs educating patients about their healthcare system, maybe educating them and training them to be a better engaged patient. And that's something I would like to see. But thank you so much. It was really informative, and Karen, your story was moving, and like all activists, you know, things happen for a reason, and maybe that's why we're both here today. Thank you.
Thank you.
Back to you, Chuck.
Now what we'd like to do is have Matt and Colin in California first react to Mary and Karen's wonderful presentation of really practical tools, and have each one of you make a comment about that, and then a comment about Carol Sanford's work, because I think Carol's work is really what Karen and Mary are doing. They are social entrepreneurs. They are bringing new innovations to us and bringing those in a way that creates new thinking, big barriers, big challenges, but they're going on hope and the belief of a cause, not a business model. And the business model comes from that, and hopefully we'll all buy their books to help self-fuel it. But it is driven by the cause that started with patient safety being at the heart of it. So Matt and Colin, would you please first react to what you heard from Karen and Mary to reinforce or make your comments, and then just a comment about this social responsibility that we're seeing now across all industries and that we've seen with Carol Sanford's work. And again, we have no relationship with her other than admiration.
Yeah, absolutely. Hi. Thank you to Karen and Mary for your tremendous work. I've personally and professionally been an admirer of your work for quite some time. I think you're making great headway in healthcare, which is desperately needed. So thank you for that hard work. One thing that stood out to me was one of my favorite quotes, the Einstein quote that you mentioned, where you cannot solve a problem by using the same thinking that created it. And to me, that refers to an issue of perspective. And I love that there are two guidebooks here, one for patients and one for caregivers. And the way that you guys have partnered together shows that you're interested in the perspective of each other, which can frequently be difficult to grasp. And so engaging patients through caregivers engaging patients by trying to get their perspective can solve these problems that are systemic in healthcare, because you have someone who is looking at it from a different angle. They're obviously, invested in solving the problem. So that engagement can lead to a tremendous number of solutions. And as you get those solutions together, there are things like recording of the discharge instructions, which has reduced readmissions, for example. That's a tremendous example because it aligns with the head, heart, and the hands approach that you've also outlined, which is a wonderful way to get things to stick for people and to create actual change. There's the head piece. You've got the information that this is an activity that we can do, and it's got a tangible result, which not only appeals to patient satisfaction, but it also appeals to the bottom line of a hospital, which is, that's important. And as we see the pressures coming from the payers to reduce those readmissions, this is something that can have an impact on that while simultaneously increasing the patient satisfaction and benefiting the outcomes altogether. So it's a win across the board, which is attractive because of the three elements of the head. It's information, it's the heart, it's got this emotional impact of something. It's got an aha to it, and then there's the hands. It's an actual thing that you can do that's outlined. So solutions that hit across all those three are going to be extremely effective. They're going to be easy to sell to other people to get them to do it and get it on board, and they're the most likely things that are going to change the behaviors. As Hillary Schmidt mentioned, getting out of these habits through education. It's not as simple as giving somebody knowledge. You have to appeal to them on an emotional level as well, and a logical level, and those combined approaches are really going to stick and get things done. I'm going to hand it over to Colin.
Great, thank you. Colin, go ahead.
All right, yeah, my comment is just a little bit more from personal experience. I had a family member in the hospital about a year ago, and one of the things that I did was I took the booklet with me into the hospital, but also left it for the people who were also transitioning as caregivers after me. And mainly we were just sitting by the bedside, and it was something to read. But one thing I noticed with family members and friends of my relative was that they had commented that it really allowed them to kind of look for things, because everybody was very concerned while, in this particular case, it was my sister laying there on the hospital bed, very cold, very disoriented, and not able to really ask many questions herself. But the checklist gave us kind of the tools of what to ask the nurses on, when they came into the room, what to be prepared for on discharge, things like that, which are, when you're watching a loved one in a lot of pain, your mind isn't working quite right. And so this book gave us a lot of the ability to kind of think coherently about what needed to happen. And I think the nurses actually benefited a lot from it, especially in the case of the disinfectant near the bedside and constantly wiping off the bars to the hospital bed and things like that. I just felt like that it gave me this sense of security while we were there, and the ability to kind of interact with the nurses on an equal level. I know quite a bit about healthcare, but my family and friends do not. And so while in that hospital room, they got a very quick education on what to look out for. And I think that's how most people generally look for knowledge, is only when it pertains to them, only when there's a concern do they access the internet and kind of index, what is this new disease that my doctor is talking about that I'm at risk for, or so on and so forth. So having something handy to pertain to whatever incident might arise really does benefit the patient, but also the caregivers in those conversations that inevitably follow, in order to cut the time out of nurses' busy schedules, in my opinion, because I think a lot of the nurses look thrilled that we were constantly disinfecting, constantly reminding them to wash their hands because they had just come from a room previous with an emergency or a delivery or whatever unit that they were transitioning from. So it really proved to be something that gave us security and peace of mind. And in regards to Carol Samsford's work, I think that what she has really outlined is a holistic way of looking at running a business. It really is, if any hospital leaders or administrators are having a problem transitioning to something a tool like this that can be used, what a lot of Carol Samford's work does is take a look at the whole entire systemic way that business can impact both the employees but the ecosystem outside of that, all the way up to from suppliers and down to the patient level in the case of hospitals. So I think that what these tools do is really help us to kind of make the business case for the tools that are going to enable people, especially the patients. In my opinion, we became more part of the conversation as we were interacting with the nurses and the doctors that would come in with their various teams. And Mary, as you said, the acronyms in healthcare are very daunting someone who's unfamiliar with them. And just in the case of MDRO, from a patient standpoint, that sounds like the end of the world. So it's very nice to have not only a tool to help you, but a business case and a level of understanding that can help the leaders that have trouble looking at their bottom line, or whether this is going to impact like workflow in a hospital situation. These things can kind of help people move along that story or that trajectory. So that's my comment.
Thank you so much, Colin and Matt, for your comments. And because we want to move quickly to our the Q&A, what we'd like you to do is give us some polling answers to these scorecards. We are getting an enormous amount of pressure to help move the scorecards to a better level so that everyone, patients and families, can use them. So these are important questions that we'd like to have answered. And we'll just go through them very quickly. The slides are up on the slides, but in your lower right-hand corner, there is a window that is open called polling. And if you believe strongly that the scorecard that is described in the question, so the first one is the patient safety indicators overview from our scorecard would be valuable to a family seeking care. This is to families. Would they be valuable to your family or to families you know that might not be healthcare workers or knowledgeable? You would give it a 10. That would be your highest recommendation on a Net Promoter Score basis. You'd say, boy, I very strongly agree that the PSI ARC scorecard would help a family that is not a clinical family, not a family where a doctor or a nurse or a pharmacist is a leader. We're talking about families that you know. And we'll go through each one of them. So the first one is the patient safety indicators. Give it a 10 if you believe that it would be valuable to families seeking care. And you can be tough, because I think we need to really get some good results here to figure out what we could do on scorecards. The second scorecard is Hospital Compare. And if you believe that the Hospital Compare scorecard would be valuable to patients and families, give it a 10. If you think it isn't, the worst you could give it would be a 1. The third one is MedPAR, the Medicare Provider Analysis and Review. And some people are unfamiliar that these even exist. But whether these websites or scorecards would be of value. I'm on the next slide, which is the Partnership for Patients. Is the work of the Partnership for Patients, and maybe not the scorecard, but the work and what is presented by the Partnership for Patients on the websites, are they of value to patients and families? The next one is Consumer Reports, and I may be going faster than you can fill out the polling, but I just want to make sure everybody understands that the next one is Consumer Reports. They rate hospitals in their publications, and many of you have seen them. A 10 would be your highest recommendation. A 1 would be very strongly disagree that they would be of value. And then one of the proprietary ones is health grades, and that's the bottom one on slide 75. The HCAHPS hospital survey, the Hospital Consumer Assessment, Healthcare Providers and Systems Scorecard, or website. So if it's not exactly a scorecard, still give us your impression of how valuable this would be. The next one is those that achieve the gold seal of approval from the Joint Commission. And again, all of these are in the article by Modern Healthcare. Very strongly agree would be a 10. Very strongly disagree would be a 1. The Leapfrog group at the bottom of slide 76. And again, you're filling out the polling on the right lower corner of your screen. And then the next one is the PEAK, the Performance Empowering Analytics and Knowledge Scorecards. The next one is the 100 Top Hospitals from Truven Health Analytics, and some of these are proprietary. And at the bottom, probably the most well-known, or one of the most well-known, is the U.S. News and World Report Best Hospitals, and yet they really only represent a certain number of the hospitals. And now coming back to really this issue of patients and families, one of the biggest areas on slide 78 is malnutrition. A recent article that came out in Modern Healthcare with a video about Detroit addressed malnutrition in our lower socioeconomic groups is a major driver of readmissions. And we know nursing care and home family caregivers, it's always in the top 3. Diet is always in the top 3. And it turns out that malnutrition And nutrition is a major issue on readmissions, not just whether they get the meds or they see the primary care doctor or whether they have a callback system, but really whether malnutrition is. So the question is, would you like a webinar specifically addressing nutritional issues as they apply to healthcare outcomes? And we would tie them right back to the things that most of you are getting measured against and trying to overcome. And one of the least understood and easiest things to tackle is nutrition. We want to know, do you want a webinar on that? And then finally, in a perfect world, do a free text entry while we go back to Q&A on the when you finish the polling. I'll be fielding questions from the Q&A session and ask you to tell us what questions that you have of Mary and of Karen, because what we want to do is to get your questions that you'd like to have asked. The final question we want you to fill in free text entry. In a perfect world, a quality and safety scorecard for patients and families who are consumers, not healthcare workers, but consumers, what would it be? And if you've got something that you think is a really good idea, or what you think that the ideal would be, go ahead and put a free text entry into that. And when you're done with the poll, go to the question and answer sort of section. And one of the first questions that I'd like to direct to both Mary and to Karen is regarding this issue of the fear of patient safety issues. There's an awful lot of fear. We know the ARC study, Mary, showed 600,000 staff workers in hospitals. A survey of them revealed that 37% would not report an error when it was happening, would not report something that they know would have a direct consequence, a patient safety consequence, because of fear of retribution. We also know that in the recent National Patient Safety Foundation debate between two healthcare leaders, that a majority of the audience still felt that penalties might be a better approach than systems improvement, and yet we didn't watch it and don't know about it. But we do know that there is, this debate on whether, and the punitive side of things and the fear around patient safety to get caregivers and nurses to be stepping up and really helping patients and families. Can you help us address that, Mary, with your thoughts?
Well, Chuck, thanks for highlighting that, and it's a very sad state of affairs that, we have that high a number of people telling us that there are still bad consequences for doing the right thing. And, we have not achieved what Lucian Leap started talking about well before, most of the literature reflected the blame-free environment. It doesn't mean people aren't accountable, but we don't have a safe climate. And there's a lot of pressure to conform and just get along to go along, and I think that's tragic. It starts at the leadership. So the leadership has to role model that, that kind of behavior is not acceptable among themselves or among providers. And then we have to really look at our schools of medicine and nursing and pharmacy and make sure that we're preparing people to be courageous and to be advocates, because it is, in my mind, otherwise unacceptable. So we've got work to do. I think, for example, the CUSIN program may be helping a little bit in nursing, that if new grads are coming out with new messages about working in a safety mindset, that might help. But what I'm afraid of is that the current workforce might discourage them or push them back in such a way that they're intimidated. So we've got work to do, both from a family perspective, a professional integrity, and from our leadership.
Great. And then if you could, anything you want to add, Karen, and then I'm going to go to a couple of the questions that we have in our in the panel on the lower right screen. And again, enter your questions. But Karen, this, we tend to eat our own and still get into a name, blame, and shame cycle to protect our system. So when we have a system failure, we tend to vilify the victims, which are our own caregivers, even if it was a total system failure. And then we also know in the malpractice space, the first thing that hospitals will do is vilify the family and try to lay blame to reduce their own costs. So there's a lot of fear that's the elephant in the room. Any comments?
I really have, both of you have covered it so well. From the patient and family perspective, it's absolutely horrifying, and certainly not what, just if I go back a few years ago when I had absolutely no experience with the healthcare system, and I was approaching it with all of the trust and faith and optimism and very high regard and respect for the brains that work in hospitals, the smart, caring people. It's a complete disconnect to think that the systems which govern their practices and what they are able to do would be punitive, would not celebrate catching potential errors as a way to move improvement practices and policies. It's just astounding to me, and I really don't understand why this kind of culture exists or how it was started. I think I can't even add to it, except that I do feel it is a betrayal of patients and families who do go in with trust not to have the systems lined up for continuous improvement and celebration of the good catches that people can make. We're all humans, and people will make mistakes. It's just what you do with them that really separates the high performers from those who are really very mediocre at best.
Well, thank you. We could go on with Q&A and dialogue with you, and we really want to invite you all back. However, I'd like to give a chance to our audience actually to ask some questions. And Sonali Muzumdar, and I know I've mispronounced it, so Sonali, forgive me, but her question is, we do med safety rounds at my hospital. We would like to incorporate our patients in these rounds. Are there any questions that you would recommend that we ask our patients on these rounds? Mary first, and then Karen.
Well, I think that's a wonderful idea. One of the questions that I think it shows right up on the HCAHPS tool is, did the nurse explain your medications each time? And the difficulty of it, that gets into the plain English. And I don't think we want to, have to give the left bundle branch block, effectiveness of beta blockers to every patient every time you hand them their meds. But the clear understanding, the teach-back methodology, very important. And there might be questions, did you understand it? Was it explained to you? That would get to a deeper, to a depth that I think we're going to start to see uncovered in the HCAHPS calculation. And it might be also a huge safety factor, because if someone understands what they're being administered and that's not what they take, or they have an allergy, you could stop it right then and there. So what a wonderful idea that would be. I've also heard, just to just steal the show for a second, in terms of fall protocol, one of the post-fall huddles, to be sure to try to include the patient and or family in that huddle as well, to really have them talk about what they think happened, and let it be perhaps that teachable moment about, okay, next time don't use the IV pole, it's on wheels, so let's, talk about how that particular event took place, but to include the patient and family, which I had not heard as a common practice.
Karen, do you want to comment on the questions?
I think the importance of how to take medications safely is also important. And again, the teach-back method can be used very well in this kind of scenario. We understand there was a study that came out of Yale about a year and a half ago, that 75% of all patients aged 64 plus went home with an incomplete understanding or really misunderstandings about how to take their medications at home, or they had an incorrect prescription. And we also know that about a third of the readmissions are medication related. In other words, people aren't taking them or they're taking them incorrectly. So this idea of helping people to understand what they're taking, but also how to take their medications properly is also critical. And in the pediatric population, it's even more critical. I've been on the patient safety work group for the American Academy of Pediatrics, and a big problem is for pediatric patients, little kids. As you know, a lot is determined by weight, but interestingly, more ED admissions result from inadequate or overdosing kids, really, because a teaspoon, if you give a teaspoon of a liquid, usually for kids it will be a liquid, that it's not okay to take that teaspoon out of your kitchen drawer. There's a teaspoon that's a unit of measurement that is often provided with the medication itself, but nothing else can be substituted for that. So that kind of education about how to take medications when people are on their own, if anything could be done at bedside, it would be a wonderful service to patients, and then of course with parents in children's units.
We could probably move to Arlene if there aren't any other outstanding questions or comments. And Mary or Karen, do you have any final closing thoughts before we move to Arlene to close the webinar?
Oh, this is Mary. I really want to thank everyone for participating. I saw two questions, one about how to work on culture, and I think that there have been some TMIT webinars on getting the boards active, and I think the entrepreneurial work and having integrity as leaders is work that Chuck's been very much part of. So I totally understand that the culture isn't healthy. A lot of these practices are very difficult to implement, and it really requires extra effort. So I do think that there are some resources that could be discovered, and I think TMIT would be a good place to start looking. The other comment that I saw in the Q&A was the fact that chemicals are required to be kept locked up, and so how can we give out cleaning materials? And I think that's a fine balance, because we certainly don't want hazardous materials out and about. We have children and elderly who could perhaps be exposed to it dangerously. On the other hand, cleaning materials, let's not forget soap and water, and some of the commercial wipes that are not hazardous, that are readily available. In fact, you can bring them in from the grocery store, really could be more prominently made available. So I don't want us to violate any Joint Commission Environment of Care standards, but I do think it's important to start reinforcing the cleansing element of what can be made available to patients and families. So I'm going to have to close. My battery is actually about to die on my phone. Technology is great when it works.
Thank you.
Thank you so much. Thank you so much. Unfortunately, I lost my line, and I did it myself, so I'd like to apologize for that interruption there. But I'd like to just thank a wonderful set of presenters. It was fantastic, and I really appreciate Karen's comment regarding children. My little boy Charlie, on my lap in a hospital in California, almost got a double dose of his anesthetic to go under general, and the anesthesiologist caught a conversion issue from pounds to kilos. And so this can happen to any one of us, and it was a near miss that just shocked us. And when he left the hospital after his surgery, I was so much in the fog of war of what happened. I did not get his postoperative antibiotic, and he got a post-op infection, and it was my fault. And I'm a caregiver and a safety guy, but that fog of war issue and the stress is so critical, and Colin, I know, brought it up. What I'd like to do is just ask Arlene Salamandro to close us and if she didn't while I was off, I'd like to have her close us and thank all of you for a wonderful webinar, and ask the speakers just to stay on for a minute so we can do a rapid cycle improvement loop to see what we can do better next time. So Arlene, would you close us?
Okay, thank you, Chuck. I just want to thank everybody for being on the webinar. I just love the conversation where we can openly talk patient side and healthcare side. And patient-centered care, does that end when something goes wrong? I think that's when patients need you guys the most, when things go wrong. And I think we need the honesty. We don't need to be stereotyped into a category where we're all going to run to a lawyer. I think we need to be, our cases are individual. What happens is individual and unique. And apology goes a long way, and discussion, changes that come from it, that's everything. So I'm so happy to be here, and and the information that was presented, if you could go out and share it with someone else that wasn't on the call, that would be great. So thank you very much. I hope you have a wonderful day. Thank you.
Thank you.
Thank you so much. Have a good day. And if Mary and Karen could just stay on just for a minute.